Good morning, everyone. Welcome to this session, this brand new session on the presidential lectures. And let me just start with the introduction. This session will be mostly dealing with the efforts that SIOP is doing for supporting research, mostly in low and middle income countries, with the PARC program. The PARC program was Kathy Pritchard-Jones' project's idea back in her presidency. I am deeply honored to follow her steps there in that program and hopefully make it bigger and bigger with time. So the first presentation will be, in fact, Kathy presenting about the SIOP vision to support research capacity in low and middle income countries. These are not the slides, right? These slides are for the next presentation. Can you please upload Dr. Pritchard-Jones' slides, please?
It was a bit late to upload them, but hopefully they're there. Maybe they're putting them. Good morning, everyone, and thank you for being here for this very important presidential session, an innovation by Guillermo during his presidency. And he asked me to come and speak shortly about the vision for why we developed the program for advancing clinical research capacity with a focus on low middle income countries. So this was gold, as I'm sure you will know, in our SIOP research strategy, which is now sustained for the next 5 years. We have 5 goals. Goal 2 is all about research, under which we aim to facilitate research collaborations, recognize research excellence, and we had a fantastic Hans-Peter Wagner award lecture this morning, and I think there are more prizes going on in the last session. But critically, to identify gaps in current research and evidence base relevant to localities, and to promote research to address these gaps. So when we were developing the SIOP strategy back in 2021, I was very grateful to Peter Adamson, who at that time had just handed over the chairmanship of Children's Oncology Group. We sent him the strategy for his thoughts, and he gave us the provocation. He said, Kathy, you need to have a big, hairy, ambitious goal for your society. You know, the strategy's great, but you should, try and do one big thing. And I think it's thanks to Peter stimulating us and the SIOP board agreeing to develop this that we developed the program for advancing clinical research capacity in low and middle income countries. As our BHAG, as it's called in the jargon. And it's amazing how quickly it got established, and I think thanks to the SIOP board and also specific program help from Tessie Laub, who's in the audience, we established the PARC committee in just under a year, and the call to membership to be on this committee was enthusiastically risen to by our membership. So what was the rationale? And what are we trying to do? The goal is not for SIOP itself to carry out clinical research trials. We're not a clinical trials organization. Rather, our focus was on being able to support building local and regional capacities and infrastructure, to develop the necessary workforce, and also to encourage and put in contact our continental leaders with potential stakeholders and agencies that could help with funding in their continental regions. And why do we need to do this? Well, we all know about the so-called survival gap, which is variably quoted as 80-20, or maybe now 80-30% on average for LMICs. And of course, many upper middle income countries are very close to that 80%, but there's a huge disparity. But in fact, the research gap, as opposed to the survival gap, is even greater. And I want to point you to these 2 publications that came out in the last few years. Back in 2020, Pam Cairns, Richard Sullivan, Dr. Sirimi published this analysis of global pediatric cancer research and publications. And there's a massive gap. At least 90% of published research in pediatric cancers coming from high-income countries. And this pie chart here shows you the funding allocation. So it's even worse than 10% in LMICs. It's probably 5%. And on the right-hand side, you'll see another review carried out with AJ Major in Sam Vockelbaan's group, and they did a review of cooperative groups across the continents. And what's the world map, you can't see the percentages, but basically it's showing that about 90% of children with cancer live in low middle income countries. And although all those continental regions have got some existing cooperative clinical trial groups, the children themselves are very poorly covered. The outputs of those groups is not massive like it is in Europe, Australasia, and North America. So that's what PARC is trying to address, this research gap. And this shows you the timelines. Guillermo may well go through this again, but I'm really impressed with how the SIOP board have taken this forward, and particularly Guillermo under his leadership. He very generously agreed to take on leading this program as he became president-elect. So you come into SIOP and you've got to hit the ground running, and you get asked to do a lot. But you can see that we started with a needs assessment, so we didn't just say this is what we think is needed for research in low middle income countries. We did a proper survey of the existing clinical trial groups. It was very helpful to have had that global mapping done previously, but actually I think we pretty much knew everybody. We asked them what their key priorities were, their needs were, and so we then developed a call for proposals that was going to address those needs. And the funding that's available is completely unrestricted. They can use it on building capacity, the sort of thing that's very hard to get research funding for normally. And very coincidentally and helpfully, at the World Health Assembly in May 22, there was a clinical trials resolution recognizing the importance of having more equity in clinical trials. But why? Why equity? Equity is important, but also you need evidence that's relevant to the local population. So PARC itself has got 2 publications about the program. We published it in 2020, and these are open access in cancer control. And we have an article in press that will coincide with the London Global Cancer Week online webinar that are going to take place in November. So you can read that article, which gives a practical update on what we've done in the first part of PARC. And I just want to finish by acknowledging massive support for this program, particularly for Peter Adamson for the stimulus to do this, the SIOP board for agreeing that we could do this. Amazon Global were very generous with support over 2, even 3 consecutive years that allowed us to really launch the program with some meaningful funding, not massive, but meaningful. Foundation S have also come in more recently, and the it's the Nikon and Irene Chung Family Career Development Award. I realise my acknowledgement slide is the one I was correcting, and we just heard more about that. And then most of all, I'd like to thank Guillermo Chantada for leading this, and Tessie Laub and the SIOP office for their support in executing it. Thank you.
Thank you, Kathy. Thanks for your vision and your leadership. This project was really incredible. We are still we are trying to make it bigger and hairier, and you see the support we have is really important, but we still need a lot to support. So can I have the first slide, please? Here. Okay, so I would like to touch upon a few topics on the why are we doing this at SIOP and the challenge we face for the clinical research in low and middle income countries. These are my disclosures. So as Kathy mentioned, this global disparity is well known by all of you. It's not necessary to address it further. You know that the survival rate, this is a seminal paper, the survival estimates on childhood cancer are not equally distributed around the world. So research is an essential component to improve the situation. We all know that everything we know about how to treat a child with cancer, we know it from a research study. And this is also valid for low and middle income countries. And quoting Lady Gaga, there are million reasons for this. Most of them are well known by everyone, that insufficient access to high quality care, there is no universal health coverage in many countries, a poor governmental investment for treatment, let alone for research, late diagnosis, low availability of chemotherapy drugs, high toxicity of the treatments proposed in high-income countries, poor treatment compliance, and the topic that we will deal today is low investment in research. And as Kathy showed, there is a mismatch between the disease burden and the research activity. So only 10% of clinical trials are in children all over the world. And 9% of all the trials in children are done in LMICs. And of those with cancer, most of them are done in supportive care. There's very little clinical research in low and middle income countries for pediatric cancer. And the questions we ask ourselves is, why is that? Are children really, some would say, but we should protect children from research. Or conversely, are they denied the right for a better treatment? If we all agree that a better treatment is based on research, we are really not allowing many of the children of the world to access the better treatment by not accessing research. The other question that could come up is, why do we need research? Why don't we do the same as they did in high-income countries and just translate it to our setting? Well, we all know we have the area work that is showing that we need to adapt. But we need to adapt, but then we need to measure these adaptations compared to other adapted treatments, how they implement in the settings. So it is, for me, at least for SIOP, it's not the luxury that we can't afford, absolutely, because we cannot use the available evidence as we have it now. So as Kathy mentioned, we are very lucky that the WHO is also working very highly in this resolution for strengthening the clinical trials all over the world, but with a focus in low and middle income countries to provide high quality evidence and improve research all over the world. That is probably a consequence of COVID. Many of the fundamental research studies for COVID came from low and middle income countries, even the vaccines. And this is a paper that I would welcome you to read. This is, was published a few months ago from a work that we did also in collaboration with the WHO for strengthening the pediatric clinical trial ecosystem to better inform policy and programs. So the limitations we face are many. As I mentioned, it is conceptual. I always said this is the trump of the evidence-based medicine, because we like to apply evidence-based medicine, but first we need to generate the evidence, because the evidence we have is not sufficient. Of course, there are financial issues. We are, as I said, we are not hairy enough yet. We need more hair, become bigger. There are limitations for international data sharing. We are dealing with rare tumors. It's not possible that a country does not allow to send information, anonymous information, to another country. We have to do something. There is also a risk aversion, especially by the IRBs in many low and middle income countries, that will not take the risk of performing a clinical research that is usually of low risk and with intention to improve the results of survival in their children. And of course, there is also some strategy decisions from the pharmaceutical industry and regulatory agencies. In many countries, the regulatory agencies only approve the new drugs for the indication that is approved in high-income countries, which again doesn't make any sense in many low and middle-income countries, as we would say, as you will see here. So then we get to what I call the on-label paradox. We as pediatric oncologists were usually complaining that we have all the treatments that we do off-label because there were no pediatric studies done in our chemotherapy, but now we do have, but these on-label are applied wrongly, in my opinion, in low and middle income countries. Like, for example, the example of naxitamab, which is only approved for relapse or refractory high-risk neuroblastoma. It doesn't make any sense in low and middle income countries. That will not change any survival rates if we spend €500,000 to treat a child with relapsed neuroblastoma. The same with dinutuximab. And it was even described as the first global approval, which it is not including the global south. The way we need to use these new drugs should be adapted to our reality. This is a work that Jacques van Heerden has published, for example, in neuroblastoma in low and middle income countries. You see in the upper part of the slide the treatment of neuroblastoma in high income countries, and in the bottom part, the way we treat the limitations we have in low and middle income countries. How are we planning to use anti-GD2 treatment if we are not able to solve these problems? But still, there should be a role for these new innovative treatments. If we think differently, if we try to change our mind and think how in these systems these new drugs can make a difference, because we can. And we tried in Burkitt's lymphoma. You know this slide we did with Scott Howard a few years ago. You see that in Burkitt's lymphoma, you know that the results are different all over the world, and are different because we have different events. Probably most of them are because of toxic mortality. So, for example, the introduction of rituximab in Burkitt lymphoma made a substantial difference. These are 4 studies. One of them is a Hans-Peter Wagner Award from SIOP, showing that reducing chemotherapy, which is completely out of the question in high-income countries. Nobody would try to reduce the chemotherapy for a Burkitt lymphoma. But if we reduced chemotherapy and added rituximab, we improved the results. And we improved the results in Russia, in India, in South America. And you see here how this can impact survivals in a population. I'm sorry for the Spanish, this slide is in Spanish, but this is original data from the National Registry of Argentina. So you see here in this slide that when we added rituximab to the regimen, we were able to go up from 65% survival rate in Burkitt lymphoma to 83% survival rate. The only difference in that time is the use of rituximab. And it is not because we had better supportive care, because we didn't see the same in AML or ALL. So this is the use of rituximab in an adaptive treatment. So we can make a difference, but we have to think of different ways of using these new drugs. So what is SIOP doing this? SIOP is trying, as we do now, to convening and coordinating efforts. We don't do the research ourselves. We support the cooperative groups to do it. We may help in prioritization to make your voice louder, to strengthening the networks and connections and create consortia of excellence, so training and advocacy, and also to provide our influence. SIOP can have a multi-stakeholder influence. We can try to influence the governments to support pragmatic clinical trials and to use the information from pragmatic clinical trials to approve the drugs in the different uses in low and middle income countries. We should make the governments help us for data sharing, to also help us to facilitate customs entry of reagents for diagnosis, for example, review of the authorizations of the new drugs. We also work closely with the parental groups for advocacy and support, for alignment of priorities. Our priorities are always aligned to what our parents of our families of their lived experience with cancer advise us. We also have to influence, again, the IRBs. We have to need more expedite approvals. If a protocol from Gallup, for example, is approved in Brazil, should be approved very quickly in Chile, for example. So we need less risk aversion. We have more coordination. We need data sharing. And of course, also we can try to influence the pharma. We are doing already that. And to rethink their marketing strategy in low and middle income countries and use adapted research for approving the drugs in these settings. They will sell more drugs. We will save more children. Everybody will win. So with that, I thank you very much. And let us move on to the next presentation, because it is... thank you. Thank you. So not only clinical research is the tools that SIOP can offer for research. So the Global Mapping Program, for example, offers a great opportunity for research, and Maite Gorostegui is going to show that in her presentation. Thank you.
Good morning to everyone. It's a pleasure to be here and present you global mapping as a research tool. I have clearly problems here, so just a moment. I don't know why not. It should come. So we wait a bit.
We don't have the singers of yesterday for entertaining. Oh, sorry.
It's now. Let me see if I can. Yeah, nothing to disclose. Yeah, this is for you to have an overview how the status on data collection is. So we, as you know, many of you, we are mapping every facility in every country. And at the same time, we are collecting data that address the essential care of the children. And we have already finished the mapping in Africa, in Latin America, and we are planning by the end of this year to finish the data collection in Asia in a formal way. We will continue, but to be able to do the first analysis. And in last April, Oceania started as well. So it's wonderful how this is going on. Then it is a challenge to mapping and also to understand the pediatric oncology capacity across continents. As Guillermo and Kathy mentioned, there is such a socioeconomic heterogeneity in the same region, in the same country, even in the same city, in different hospitals. Clearly, we don't have enough data about the pediatric oncology workforce. Some data come from high-income countries and talk about distribution of pediatric oncologists, but we don't have enough data. And the workforce, our workforce, that is so multidisciplinary, impacts directly on survival. And the access to treatments. We are also collecting data about this, so it will give us essential information to collaborate. We are identifying gaps, and this is the final idea, as I mentioned, to be able to strengthen collaborations. And this is something that is already happening. In the methodology, many of you know, we have 10 core questions, but it depends what do you want to do with the mapping. The mapping belongs to you, not to us. So, for instance, I can share with you that in Oceania we have 30 questions. In India, they designed the mapping with more than 90 questions. So this is also is something flexible. We have a secure platform. Our partner is Resonance. And the data that we have can be updated. This is good because it's a measure for improvement. You can compare along the years how the reality in your country, at your institution, is changing. This is a beautiful example about how global mapping can give you useful information. So in Latin America, we know, all the Latins, that most of our children are treated at public institutions. But this number that is here in the second part, that 60% of the children are treated in 70 hospitals, when we know that we have more than 300 from Mexico to the end of Chile, is something very important, because that means if you want to do research, you can address these 70 centers, and you will have a number of patients that is representative. And if you are working, doing policy there, if you target these 70 centers, of course, you will have an impact in many, many children. And we were also able to define very well where are the limitations in the workforce in pediatric oncology in terms of number of pediatric oncologists per new patients per year, if the nurses have time to become a specialist. We we reported that 88% of the nurses need to rotate to other boards, and they don't have the time for specialized. So there are many challenges in the regions. Surgical oncology is another example as well. In India, at this Congress, you will listen Dr. Amita Trehan. We are sharing the interesting data coming from India. And I will just mention something that caught my attention, and also I'm sure that people that is working in pediatric oncology know that adult oncologists are involved in care at half of the centers. So this is something that is very, very important to understand the reality of pediatric oncology in India, and there is a need for more trained staff, as in Latin America as well. In Oceania, that is in progress, some emerging data are coming, and here, what I really like about this mapping is that they introduce a second objective, that is to know how is the landscape of learning, of training. And they are observing that outside New Zealand and Australia, the possibilities for training are limited. And in most of the centers, the pediatricians are taking care of children outside these big countries. And I am waiting for all the results coming from Oceania. Very, very interesting questions that they added. And the global mapping is something that is evolving and is giving origin to other projects, and all of you are invited to use this data and to create new projects to use global mapping as a tool for research. And I would like to mention one of the projects that is about to begin is a project, and we have here Dr. Carolina Isurieta. She's the principal investigator of the mapping on survivorship units. They will map the units, the resources, and this is an example of a huge collaboration between CCI, PAHO, SIOP, St. Jude, Seattle Children's Hospital, Hospital St. John de Deu. So that is, for me, is the beauty of this mapping, that we really have opened the door for collaboration. It's not just for publishing papers and know in the scene of knowing. It's really can change and shapes realities. And in Africa, now Dr. Gil was explaining that the idea was to update the data that they already collected, but now addressing GACC priorities and try to find also a way to collaborate. So global mapping as a tool for research gives you information that is key. This is really something that I can really confirm. You receive information to collaborate with authorities, with partners, with people that want to change realities, helps individuals. It's not owned by SIOP. The mapping belongs to you, and the data belongs to the institutions. It's clearly more than a map. So thank you to everyone that has completed the survey, to the ones that help us to identify institutions, and everyone who comes with inspiring ideas, to Foundation S for funding us, and Resonant Health. Thank you very much.
Thank you very much, Maite. Well, this is showing also the power of SIOP in supporting research in activities related to global mapping. Here, again, this project was initiated during Eric's presidency. It is continuously growing over the years. It is interesting because we see the map upside down. We see more lights in the global south than in the global north. So it is showing the potential of the collaboration of the global south for this kind of projects. So I'd like to also thank Foundation S for the support of PARC for global mapping and for other initiatives in research that we do. So this second part will be a panel. So we will not do any more presentations in this second panel. Dr. Karalan and Girish Chinnaswamy are the current chairs of the PARC committee, and we would like to invite the chairs of the cooperative groups to come up to the podium and to the table, and we will have a series of questions and answers regarding their experience participating in the PARC program. And one more thing before we go, it's just that hopefully by the end of the year, as I said yesterday in the opening ceremony, we will get to the first €1,000,000 for support in PARC, which still is not hairy enough, but still is €1,000,000 more than when we started. So it's a great milestone for us to be celebrating this in this symposium. So. I will go there.
All right, thank you so much, Guillermo. So I'm Carl Allen, and along with Girish Chamswamy, we're the co-chairs of the PARC committee. So we do have a few slides just to tee this discussion up. So my job is to introduce what PARC is, what's happened over the last several years, and then hopefully have a discussion about how we can make the biggest possible impact in children with cancer globally through research. So I don't know if we can get this slide up for Carl Allen. I will say for my co-chair, it's been great working with Girish. I didn't realize how unbelievably popular he was until walking around the halls with him. I like to say he's the Kevin Bacon of pediatric oncology. Everyone has worked with him with Tata Memorial or at Tata Memorial, and so it's. I think he brings a unique perspective, and I think also is an example of, I think, where the field is going and what the power of PARC is. So again, for the committee, over the last couple of years, Girish and I have co-led this, and then you can see our other committee members represent experts in the field from around the world. And I just want to take a minute to highlight Tessie is an amazing hub of our program and kind of keeps everything together, and because of her it works, and I think we just need to take a minute to recognize her, and then also recognize that €1,000,000 is an amazing accomplishment so far, but if you think about it, like what's been accomplished with basically the equivalent of a single R01 grant is pretty remarkable, and I think there's a lot more we can accomplish with even more resources. So we've talked about all of this. What's the point of doing research in pediatric oncology? And I think historically there's been maybe a little bit of an aversion to baking research into global oncology because of concerns of relevance, concerns of equity, concerns of ethics even. But it is really part of what we do and who we are as pediatric oncologists. And I think we're realizing that taking protocols from the US and Europe or even risk adapting them doesn't do the job. We need to be able to get data on our patients in real time for all the reasons we discussed. So pediatric oncology is a team sport. I think we all kind of have lived these curves at some stage or another in our career. And I think the point isn't to have to kind of go through each of the stages of these curves in every single site, but think about, well, what are opportunities for leapfrogging? How do we know we're doing better? And I think that's really what the power of PARC is going to show us. Oops, okay. So again, we've all been part of cooperative groups. That's why we're here. That's what's brought a lot of us here. And how do these things happen, right? I think, for example, in the COG method, you have to institutions have to pass a certain bar of clinical research competence to be able to participate in COG, and then you can be a member, right? And I think what we're showing with PARC is that if we're waiting for people to be at a certain level of function, that's not going to happen. And so what we can do is to catalyze that. And so not to say, yes, you can be a member, or no, you can't be a member, but what do you need to be able to conduct meaningful clinical trial research? And I think that's really the paradigm that we're looking for. And so it's scaling up capacity both at individual sites as well as to develop networks. And so this was the vision that was described by Dr. Pritchard Jones and Guillermo to create the PARC program. And what we're going to do is, during our panel, really talk about what the experience is. And we want to be objective about the impact as well, to say, well, what's working, what's not working. So in addition to some of the discussion we're going to have today, we're embarking on an objective qualitative review of the first round of grants to see what's really been accomplished with that funding, and we'll report back to you on that. But you can see the sites that we included in the first round of funding really represent, you know, a huge part of the globe, right? So that mapping we just showed, I think we're covering a lot of the stars with these programs. And so thinking about harnessing the potential to be able to capture data from these patients is really quite incredible. Oops. And so for the people who have participated in this, in PARC so far, CanCare Africa, and you can see it's a significant number of countries in Africa. And the topics we put here, not to kind of go through bullet by bullet, but just you can scan them, you can see these aren't the kinds of things that are going to get funded on most grants, right? Like most grants are going to fund, I'm going to cure burkitt's with X, or I'm going to test the hypothesis that Y. They don't say, look, I really need a research nurse, or I really need a database to be able to do research at all. And so this really helps to kind of get to the bones of what is it that needs to happen to conduct clinical trial research. And so there's CanCare Africa, Gallup, which has already been pretty prominent, but this helps to kind of create some more connections and make some pre-existing groups even more successful. So you can see the countries represented there and the projects. The INFOG group has 50 centers, huge capacity, and you can see a lot of the tasks here are kind of ways to link those centers together. And then POEM as well. Look at all the different sites there. I mean, so there's a huge number of countries represented, a huge number of pediatric oncologists, a huge number of patients. And so we'll get to talk a bit about what the impact has been. As Kathy mentioned, there's this article that describes the bones of PARC, at least what we set out to do, and I think that's a good resource to check out. So as I mentioned, we're doing a critical review of what happened during the first set of grants, and you can see here we're going to say what's worked, what hasn't worked, what are the issues with the budget, right? Because I think we always end up at the end of a grant with money, like why do we need an NCE? Why weren't we able to spend the money? I think that's an important point. What were the intended outcomes and what were the actual outcomes? So we'll be able to report back to you on that next year. And for the second round, we had 11 proposals received, really high quality. 3 were ultimately approved. And again, these are each to $75K for 24 months, but it makes a huge impact on these sites. And so we renewed 2 sites and brought on 1 additional third site. So I see Carlos is out here in the audience, and I think Carlos has a way in meetings of getting people to think by saying, how might we, right? So I think what I'm going to do is invite the group here to think about how might we make the biggest impact on outcomes for children with cancer through research. And if we think about PARC and like what it is now and what could it be, you know, I think it has a huge potential impact. And so, for example, at the individual site, at the individual networks, well, if each of those networks can bring on new sites over the next kind of years, that's a way to increase impact. And as we create these hubs of research networks, how can we link them with clinical trials such that we can conduct meaningful international research? And then this could provide to pharma, you know, immediate access to high-quality research on thousands of children where they have to spend tens or hundreds of millions of dollars to satisfy their EMA or FDA pediatric requirements right now. So there's some real value added there. So when we have this high-volume trial network where it can really accelerate progress, and part of that, too, is bringing up the rising stars from each of these networks to be the leaders in pediatric oncology. So I look forward to handing over to Girish now for discussion with our PARC project leaders to talk about how can we globally improve outcomes for children with cancer. And so that's going to be our discussion for the rest of the session. How can we make the biggest impact in the next 10 years? And I also just wanted to take a minute to kind of really thank the vision of Guillermo and Kathy. When I first was invited to join PARC, I thought, I'm not sure what this group's going to do, but I'll join and see how it goes. And now I really see, I think this has the power to be the major engine that drives our field for the next decade. So thanks for your vision and for inviting us to join it with you. So next we'll go to... I'll hand over to Girish. Thanks.
Thanks, Carl. We have 8 panelists and we have about 40 minutes to finish the panel discussion. So we will not be getting all 8 panelists on stage. So we'll call one by one the leaders from each of the groups of the panels onto the stage. So the first panelist I would like to call is Dr. Ramandeep Arora, who will be representing Indian National Pediatric Hematology and Oncology Group. And I would also like to say that the next panelist will be Dr. Milena Villarreal from Gallup. So if you can be ready for the next one as well. If you could come on. Yeah, please. So Ramandeep, the first question to you is, I mean, you are I mean, INFOG has been the beneficiary from the first RFP itself. And as you know, India being a continent on its own and a heterogeneous country completely on its own, I wanted to ask you, you have managed to foster collaboration in India. How does your group balance the interests of different institutions? You have such a heterogeneous healthcare system with the private sector being 80% of the healthcare system and 20% or 25% only being in the public sector. So how do you align and how do you actually balance the research priorities with such a diverse healthcare reality in the country? And how has INFOG managed to do that?
So thank you, Girish, for the question. And I think I have to thank from INFOG SIOP PARC for the wonderful support both in round 1 and round 2, and which has been amazing for us. The question you pose, Girish, is quite correct, but that is not just for research priority. I mean, that's for clinical care as well. As you know, we have on one hand centers offering anti-GD2, proton therapy, blinatumab, etc. And on the other hand, we have centers with high treatment mortality, high treatment abandonment. So on a daily basis, clinicians in the country and hospitals in the country are faced with this balance of how do I get my child best treatment, but how do I get my child some treatment nearest to them. So as clinicians, we are aware of that dilemma and the challenge which we face, and we solve it. Now, when you extend the same issue in the research field and say, well, how do you build a collaborative research network? And how do you ensure that you maintain the quality of the work, but you also get access to clinical trials for the widest number of patients possible? And I think that's where it gets interesting, because there's not a template to go by. There is template for good collaborative research groups in the world, but it is not a huge template for, or a well-established template for how do you ensure access for everybody. And so I think the answer to that question is, our first guiding principle, and we have not written it down, but I think this is how we work, is we want to improve access to clinical trials to the widest number of children possible. So if we use that as our first guiding principle, then everything else falls around that. And so for making that happen, if we today have 250 to 300 centers treating children with cancer, and we have anywhere between 30, 40 children per year to 2,000 children per year being treated in centers, we have to find ways to carry everyone with us. We can't achieve it in a year, in a decade, but we have to at least put that as our goal. The other guiding principle, once you look at the first one and then you work your way down, is how do you ensure that creativity, excellence, cutting-edge work, etc., is also prospering and blossoming, and you're not curtailing that while you try to ensure access to everybody. And so for that, we have to be flexible, we have to be nimble, we cannot be very rigid. I think Carl talked about how can a center reach a certain level in COG before they become a COG center, right? So we have to be more flexible and more accepting of our limitations and let certain centers, certain studies be a certain kind, and let other studies be more inclusive, more observational, retrospective, etc. And gradually, they will all come together. And the last point I want to make is that in addition to these two things, something which we are consciously addressing now is both quality, but also inclusion of parents in carers in prioritizing research. And we've been very influenced with some of the work which has come out from UK and Canada through the James Lind Alliance. And in our own way, we are taking an initial step in getting the voice of parents and carers and other stakeholders involved in determining what the research priorities in our country should be. And hopefully we will present that in SIOP in a year's time. Thank you so much.
Great. Thanks, Ramandeep. So from having heterogeneity in healthcare and dealing with within the country, you can have a seat till both of you can. We now move on to how do we do across international borders. And I think from Gallup, Dr. Milena Villarreal, one of the key questions we have for you is that within the country, he explained about priorities being different between different hospitals, public and private sector. But across international borders, different countries having different priorities for research. How do you balance that? How do you get them all to come together?
Well, good morning. Thanks for the question. Gallup was born from conviction that Latin America needed research, high-quality research to answer specific regional questions. And that has been our guiding principle, and every priority we set is filtered through the lens of the question that is this investigation, clinical trial, or research initiative going to impact Latin America? And that's how we have set many of our priorities throughout borders in Latin America. As we have seen in Guillermo's presentation, that the WHO has supported clinical trials as a tool to improve results and outcomes of cancer patients, especially in low and middle income settings. We have been able to use this statement to further support that research in Latin America and priorities in research are very important for Latin America patients, not only to be recipients of global evidence, but to generate meaningful evidence for this region. Because the truth is that we still don't fully know how many imported treatments work in our population. And that knowledge gap can only be filled through locally generated evidence. From the beginning, Gallup has faced the same challenges and resource constraints that come across many low and middle income countries settings. So our regional priorities have been set more with funding opportunities that with real questions that come from our particular needs. Our limitations have never been ideas, have always been resources. This is why the support that we get from PARC is so important. For the first time, Gallup received direct support not for a specific disease or a project, but for its very structure, the legal, administrative, and data management backbone. So we are now expanding also the number of members and countries that are participating by strongly supporting institutions with less capacity for and less experience for research. We aim to build a sustainable platform that will allow us to continue looking ahead and balancing priorities and opportunities on two complementary goals. First, to sustain the infrastructure needed for clinical research in our region to answer genetic, environmental, and socio-economic questions that are very, very urgent for the Latin American cancer, pediatric cancer oncology. And second, to bring everyone along and to be able to bring countries with fewer resources so that no child or adolescent in Latin America is left behind the benefits of an adequate clinical research.
Sure.
Thank you very much.
Yeah, thank you very much, Dr. Villar. I just had one quick question to both of you. So what are the difficulties you faced in implementing the PARC RFP? Taking into account that the funds had to be given to different countries and you were using the money for across the countries, and similarly for Ramandeep, what was the difficulties you faced in implementing this project in India between a private healthcare and a public healthcare sector?
Well, we have mainly focused in public healthcare because it accounts for more than 85% probably of the funding for pediatric oncology in Latin America. So now we're working basically with a public system, but we have collaborations in place with private systems as well.
Okay, thanks. Ramandeep, quick.
Yeah, I think our barrier, I think the one most important barrier is regulatory. So there are certain government restrictions on how foreign funding can come to the country and how it can be utilized. And I think it has been a challenge. That's probably been the main headache in terms of making sure that we are compliant with government regulations as well as benefit from the funding. And so I have to again thank SIOP PARC because they've been so understanding in us, when we had those challenges in revising our proposal, asking them for some accommodation, taking into account this, and they were very, very willing and accommodating. So that has again helped us both in round 1 and round 2. Thank you.
Thanks. Thank you both. So if we can request you both to take your seats down. Thank you very much. So can I call Dr. Israels on stage, please? Train Israel. Okay. And I would like to call also Alejandra Mendez, please, on stage. So, Alexandra, thanks for representing CCI, and as you know, research teams traditionally have not included patient advocates in pediatric cancer, especially in low and middle income countries, and there may be various reasons for it, including hesitation from parents who feel they do not have the bandwidth to be part of this. So how have you handled that in CCI, that you're able to see the role of parents and patient advocates to actually be part of PARC projects?
Thank you for your question. And I was very happy to listen to Ramandeep earlier when he was saying that they're incorporating parents in research. That was really, I was really happy when I heard that, so thank you. So I'm honored here to represent the voice of parents, children, and families who have experienced childhood cancer in their lives. So, as I've said many times, I want to thank SIOP, Guillermo, Kathy, for your vision and wise decision of incorporating us in the discussions. So, to all, you are all the scientific community here. I don't know how many times I have said thank you for saving our children's lives. Milena, she was part of the team who saved my son's life, so I'll be forever grateful for that. People with lived experience are so grateful for what we're doing, and we don't want to be a barrier or to hinder your efforts. We want to support the work you're doing. We may not have scientific training, but a real life experience gives us a unique perspective that we believe can add value to the conversation, right? We've been there, we've seen our children in pain, we have slept by their side in the oncology ward. So we cannot cure cancer, you can, right? Yet, we are the battleground where cancer can be defeated, with your strengths and ours united. So we're also the ones who will carry in our bodies the long-term effects of this journey, right? So we need to work together. Our expertise is different, very different. You learn in a lab, in a school, in university. We learn by the bed of a child with cancer. So we have lived the disease, and living this disease brings us a kind of wisdom that needs to be acknowledged and heard. Please acknowledge our experience as another type of expertise. Our voice is essential in shaping effective cancer and cultural programs, research, public policies. We bring insight, urgency, and authenticity to the table. So we ensure that policies and research reflects the real need, not just statistics. We hold systems accountable. We drive public advocacy to push urgency and, of course, buzz-worthy coverage. So results of your research become humanized. When we speak about them, they become real, not just data. I like to say that our stories bring a soul to your data. So when we discuss the results in first person, we provide a lived narrative. So answering to your question, how can we be involved, right? So I think it's important that we can co-shape study objectives and protocols, help design survey questions to ensure they reflect real experience, ensure research reflects real needs, not only academic or industry needs. And of course, reviewing protocols to check if procedures are realistic, right? Ethics and governance, I think it's super important. We can provide perspective on consent forms, risk benefits, and participant protection, making sure that they are understandable, cultural sensitive, and respectful, right? We can also be part of the implementation and recruitment. We can act as liaisons between researchers and communities. Also in the interpretation of results, we can add our experience in the bringing out our perspective to contextualize the results that you're having. And of course, in the dissemination of findings, co-presenting at congresses and conferences, share results with local communities in ways that resonate culturally to them. And of course, help identify unintended consequences. So to conclude, I think that some suggestion of best practices for those who are doing research would be to acknowledge our experience as valuable type of expertise, engage us from the beginning, rather than just subject of research, but as part of the research, right? Make sure we influence study goals, not just implementation details, and take your time to build long-term, genuine relationships with us. Treat us as partners, not just as participants. And also I would suggest avoid parachute research, right? Respect the local knowledge and the personal experiences or stories behind. So train us also so that we can be part of the research. And recognition also matters, right? In terms of co-authorship of papers, acknowledgements in publications, inviting us to speak in conferences, and training us to take leadership roles. So I think that these have proven to go up powerful in bridging trust and research that reflects local reality. So if we include us, research might get more relevant, ethical, and impactful.
Great, thank you, Alexandra. I mean, that was so beautifully put. I don't think anyone in the room will disagree that parents and patient advocates are so critical to co-design a research project in the research study, etc. So just a quick follow-up question I wanted. From the CCI side, what do you think should be done to get more parents involved in the research? I mean, is there any move from CCI to orient parents, get them understanding the research, kind of what are all the things which you listed, so that more and more come forward? I can see some hesitation maybe there to join.
We want to be involved. We want to be involved, and we know we can be trained. We are being trained and I think it is important to, when you're at the very beginning of designing some research, incorporate what are the real needs of our children, of the families, of the parents, right? So I think it will be important, and we as CCI are very open, so open invitation for any of you who are doing research to incorporate families, okay? And I think that we as CCI would like to have a place in every discussion, stakeholders, public policies and research, and even the designing of centers. Every little thing. I was speaking to Dr. Rob Leaders from the Princess Maxima, and I was saying how beautiful the building is. And he said, parents gave us, parents guided on what they need. And I think that was a very powerful example of how listening to the people who will be using the building really made an impact in the designing of the building, right?
Great. Thanks, Alexandra. We look for more and more involvement of CCI in PARC and across all SIOP research activities. Coming to Trin, so, I mean, CanCare Africa has done phenomenal work, especially a lot of pragmatic-based research projects which have been done. How did you do that priority setting, and abandonment has been such a major focus for you? So how did you reach that and convince everybody that this is the research which needs to be done?
Thank you for asking, and again from our side, thanks to SIOP PARC, Kathy, Guillermo, Tessie, everyone for supporting CanCare Africa. Yes, why treatment abandonment? It's about impact,
expected impact. As you said, CanCare Africa has been about implementing simple, pragmatic interventions in the local context with local clinicians and choosing the ones with highest expected impact. And I think we all know treatment abandonment is non-completion of treatment for non-medical reasons. In high-income countries, it almost doesn't exist. But if we talk about Sub-Saharan Africa, the most simple and most common example is a family that has borrowed money here and there to reach the hospital for diagnosis and treatment, but sometime during treatment doesn't have the money for the bus. And then ends up in an impossible situation with impossible choices. And our clinicians see that on a daily basis. Well, the families live it on a daily basis. And then as a group, we thought we can do something about it. And regarding the impact, treatment abandonment is the most common cause of treatment failure in many places in low and middle income countries, but especially in Sub-Saharan Africa. Often more than 25% of families, sometimes and not rarely over 50% of families. And we know, the evidence is there, that it is preventable. It is preventable with simple, comprehensive, low-cost interventions. And we've seen that in several places. So that's where the potential impact is, both on the individual patient, the individual family, but also in terms of preventing treatment abandonment and increasing survival. So thinking about that impact, we, CanCare Africa, started building upon lessons learned from other parties and building upon SIOP PARC. We started in 3 centers in Uganda and Ethiopia. Now a multi-center prospective program where we are implementing a simple cash transfer program where families of children newly diagnosed with common and curable cancers get a bit of money, 200 euros in portions, to enable them to complete the treatment. And the families are getting the money and they know best how to use it. So they're free to use it as they think best. We started this program a while ago. In the sites in Ethiopia and Uganda, the teams were already there and trained by the SIOP PARC grant earlier. So we've seen that it helps. That's how we all build on each other's efforts. And with this program, we're seeing that it's highly, highly effective, as was the pilot program in Malawi. We've seen that the pilot program in Malawi was sustainable, so we're looking at that as well. And we've seen that the pilot program in Malawi was, with some assumptions, cost-effective. So we are hoping and aiming to bring our contributions in helping these individual families and helping these sites participating in sustaining this program and helping our community, all of us, to bring evidence to the table that these sort of interventions can be or are extremely effective, extremely cost-effective, and can be sustainable, and then hoping for scaling up and all of us playing our part. Whereas I would like to say that CanCare Africa is hoping to bring the evidence, but other parties really, and we're already working together with other parties as well, have to be doing the scaling up. We all have our strengths, bringing it to the table. Thank you so much.
Great. Thanks. Thank you so much, Rin.
Can I just shortly add that this is exactly what I meant, like working together, parents, instead of like researchers or clinicians deciding what parents need or giving them food or transportation or clothes or whatever. They give them the money, so they trust that the parents will know how to better spend the money. And so that's a trust and collaboration and working together. So thank you, Trillian, for what you're doing.
Thanks, both of you, and thanks for putting in perspective the role of parents in the whole project. Yeah. I think it goes without saying that decreasing abandonment will have the widest impact on achieving the goals, what we want to achieve. Thank you both, and if you can request both of you. So I would now like to call Dr. Asim Belgami to come on stage, please. As you all know, since Asim will have a lot more time once he finishes his scientific chair work, he can focus more on activities of PARC and PSPO. So Asim, this is the first time PSPO is in the RFP2 and have actually applied for the grant. What we wanted to know was, since research component is something, what we understand is relatively new in PSPO, the Pakistan Society of Pediatric Oncology. How did you get all the centers to align that we should actually go out and build a research infrastructure in the country? How did you manage to do that?
So I think there was right from the start, even before we applied for the RFP and the PARC grant, there was a belief within the Pakistan Society of Pediatric Oncology board, etc., that research really is what will drive improvement in outcomes for children in Pakistan. And so even before all of that, one of the things that we worked on was the establishment of a centralized research office. So the first things we did, and this was through a GICC grant that was received, is really establish the central office and actually hired a biostatistician, developed data management capacity within their centralized data management capacity, and then worked on implementing standardized treatment protocols with centralized data collection for the 6 GICC target diagnoses. And that's what sort of set us up. And it was that then allowed us to broaden what we wanted to do and request for the grant, the PARC grant. And what the PARC grant did was really broaden what we'd already started off on. We were collecting data prospectively from institutions, and as you asked, how did we get everybody together? And like everyone knows, it's not easy, but what we did was we allowed them to come in at their own time. So we actually started off, even with the standard of care protocols, we started off with 3 institutions. And we're up at over 14 now. And the idea was that not everybody is going to be ready to participate in it at the same time. And so let them see what's happening, let them understand how it goes. Let the institutional leaderships start to buy in at their own pace what is happening, and then take it on from there. So it's been this progress. So what we're doing with the PARC grant is establishing a national hospital-based registry, cumulative combined hospital-based registry, which really leads on from the standard of care centralized data collection in there. That also, we used our learnings from the earlier experience, applied it towards the development. So there was a multidisciplinary development of the registry format. We worked with St. Jude Care's registry program as well, just so that there's alignment with data definitions and variables that we were collecting. But we wanted it to be a PSPO thing, so that institutions that were not part of the St. Jude Global Alliance, for example, could also participate within there. And so that's really what it is, and I'm really happy to say that the pilot started October 1st. And there are 4 institutions that are part of the pilot. 2 of them are large public sector institutions, and 2 are private charitable organizations in 4 cities across Pakistan. So hopefully what the plan is to continue this for 3 months, look at what the experience is, and then start broadening it out, probably Q1 of 26.
Thanks, Asim, and we look forward to your report in 2 years' time.
Thank you very much.
And it's a great milestone to get.
I want to just mention one more point, which is that this has had spin-offs. So the 2 spin-offs, the governmental level spin-offs that's happened is that one is that the National Data Center in the National Institute of Health Pakistan actually reached out to PSPO to request help in setting up a national population-based cancer registry. So that was one, so the governmental interest. And second was, we don't know how much that we were influencing that, but the second thing was a legislation that was recently passed in Pakistan that now requires registration and documentation of cancer in Pakistan. we're waiting for implementation, but at least the legislation has been passed.
Great, congratulations.
Thank you very much.
Thank you very much, Jesse. So the next panel will call 2 speakers to discuss about barriers they had in implementing collaborative research. And for that, I would like to call Dr. Leila Hessesen, and Georg from Poems. Georg is here. I'm representing. Georg, please come. Yeah. So Leila is representing GFAOP, and Leila, the Francophone Africa, has had a long history of capacity building. Now, working with different countries, I want to know what regulatory and ethical barriers you faced, and how did you address them? That seems to be the biggest problem what we are facing in implementing projects in PARC.
Yes, thank you very much. So, GFAOP have 25 years experience in implementing research in Francophone Africa and advancing knowledge about childhood cancer in those countries within collaborative groups. So what is important to know is that we are working with the vulnerable within the vulnerable, because children is a vulnerable population, and children with cancer is more vulnerable than a normal kid. And there is an important imbalance between high-income country and low-income country, and we should take this into account, because once you are in an imbalanced relationship, ethical consideration exists. So research must imbalance patients, but not only the team, protection and security, because with the projects we can put in place, we can put in difficult situation even the team. So the ethics includes the patient and the team, and this we must balance this with the scientific progresses. Mm-hmm. So a basic outline can be what most of the moms tell to their kids. Never do in someone else's home what you wouldn't do in your own home. But this is not always possible. And if you do this, so the benefits must go to the host. You get to ensure that the benefits goes to the host. So the strategy in the GFAOP is almost and always observational studies rather than interventional studies. And research, it's mandatory to have a local approval, because we have the agreement of the French authorities for data protection, so it is mandatory to have a local approval, hospital director, and a local ethical committee. It's not mandatory to have the national ethical committee, and we need clarity that there is no need of national ethical committee review, and in our studies we avoid unnecessary toxicity and high cost, and we ask for the patient consent, the parent and patient consent. This is mandatory. And we maintain high standards in the ethical consideration. We have the data collection. We don't do study if we cannot collect data and do a regular evaluation about the results. We have statistical analysis, and we do a lot of precaution and transparency and collective responsibility, and we have a culturally aware approach, because there is some historical sensitivities and the population are different. To conclude, because the legal framework in many LMICs is not as strict and locked down as high-income country, our ethical responsibility is greater, and we must set strong regulatory and ethical safeguard to protect the most vulnerable among the vulnerable. Thank you.
Thanks, Leila. Thank you very much. Asim, if I can ask you from a poem's perspective, very diverse socio-culturally, political region, and where access to clinical trials is so variable between one country to another and has been very sparse in many parts of the poem's region. So, I mean, you must have faced huge amount of barriers, obviously, to put data together, to implement a trial, even if it is a standard of care. So, how did you address it? What are the barriers you're facing? And we understand that it is a very complicated process.
Yeah. So, first, you're absolutely right about the diversity. I mean, the region that poem encompasses has the largest and the smallest countries and the richest and the poorest countries within it. And of course, with that are the variability in the capacity to do research within it. But one thing that we felt was universal across was a lack of experience in running clinical trials. And that's what really became the initiative for starting this project in there. And the project really is for the development of a cohort of clinical research coordinators and PIs across the region that would then be able to take on and conduct research. So basically, really the basic element of doing a research of clinical trials. And I think that was something that everybody wanted, because they want to learn and take things forward and do clinical trials within their institutions. And the diversity helped us utilize regional resources. So even within that whole thing, we had institutions where there was an ability for data management or expertise in database creation, etc. So we utilized those same institutions from within the region to help with this take this forward in there. And the other thing that really helped is linking it to the implementation of a clinical trial. So there's a pragmatic clinical trial that's being instituted in the region on osteosarcoma. And so the training, which was the objective of the PARC grant, and establishment of the cohort of clinical researchers really was linked to the implementation of the trial itself. And that's really, and that's one of the reasons why it stretched out longer, because it took longer to get everything done. But again, there were a couple of things that the trial itself is ready for implementation, for patient accrual actually. And, but there were two things that came out of there. One is that the IRBs at these institutions where this was happening, this was, for them, this was probably the first clinical trial that they had ever received as a proposal. And the second was institutions themselves. They are now setting up to conduct this clinical trial. So from not just the PIs, but also the nurses who are taking care of the data managers, etc., are all starting to get primed for this. So I think, again, as what I mentioned in Pakistan, there are spin-offs to this that happen.
So, but are there barriers between two different countries that you cannot put data together and put it out in a research project? Are there like major hurdles to cross?
There are, but overall we didn't find too many obstructions. So I think the obstructions that are there are surmountable.
Sure.
But yes, there are certain countries where getting the data out of the country was difficult.
Great. Thank you both, Asim and and it was wonderful to hear you both. Thank you very much. I would now like to call Akira. Akira, yeah. So they are not beneficiaries of PARC, but they themselves are a very vibrant group, and would like to take his inputs on pediatric oncology research in the region. Request Akira to come on stage. So, Akira, I mean, AFOG is like spanning a whole range of diverse countries, from very advanced healthcare systems to low and middle income country healthcare systems as well. So what are the research priorities for AFOG? I mean, what's been the next decade? What are the areas you want to work on? Take into account the WHO goals as well.
Yeah. Thank you for giving me this great opportunity to present here today. Although APOC is not a PARC grant recipient yet. So then yes, APOC stands for Asian Pediatric Hematology Oncology Group. That is a clinical study group in Asia. And the APOC spans a wide and diverse region, as you say. Then actually, APOC was founded in 2012 and officially founded in 2021, 4 years ago. So that pre-official APOC structure was solidified by the leaders of 7 major national clinical study groups in Asia, composing of IMPOC India, JCCG Japan, so KPOC South Korea, TPOC Taiwan, CCCG China, TIPOC Thailand, and RSPOH Russia. The members of Executive Council were basically formed of the main leaders who had the experience of President of SIOP Asia, because our original concept was that both APOC and SIOP Asia should work together like 2 fields of a card, a Chinese proverb. Then yes, Asia is huge and composed of more than 50 countries, many of which are low and middle-income countries with different religion, traditions, so lifestyles and customs with different levels of education. So more importantly, the socio-economical status of each Asian countries or region is quite different. That affects the outcome of the children with cancer worldwide and Asia too. So therefore, APOC is now constructing the fundamental structure to start with the clinical studies for increasing the cure rate. So as for the agenda, first of all, APOC is undergoing nomination of members for 10 committees as the first round. So far, 75 high-level leaders of pediatric hematology and oncology were nominated from all over the Asian countries. The second round of nomination will start at the end of this year to cover all the APOC committees and by the end of March next year. The second, for conducting the clinical study, the systems of the registry and the setup of data center are mandatory. So as for the registry, so APOC will select about 10 countries and institutions to make a model networking system. Then as for the data center, 2 major data centers of JCCG Japan so already agreed to join for conducting the APOC clinical studies. So we plan to expand the data center network to other Asian countries. The third, for making a global networking to work with APOC, we plan to make an official agreement with SIOP Asia, CCI Asia, POEM, and St. Jude Global, and also other group if necessary. So finally, APOC will aim to set up the protocols of clinical studies particularly focusing on 6 WHO index cancers and even the others, including JMML, retinoblastoma, and the neuroblastoma that are going on now. So that's APOC strategy is consistent and feasible and step by step. Thank you.
Thank you very much, Dr. Gida. From the PARC perspective, we look forward for groups to work together rather than within the region to actually form a more larger networks as well. Thank you very much for
Thank you very much.
an insight. Thank you. We come to the end of the panel discussion. We thank all the panelists for their insights, and we have learned a lot in the PARC committee discussing with these various groups, which has helped us reprioritize and realign what the priorities of PARC should be and how it should go forward. Now, for the closing remarks, I would like to call Professor Eric Buffet, who needs really no introduction, former president of SIOP, a global pediatric oncologist who knows about implementing research and implementing cancer care across the world in various settings. I think he's the right person to give the closing remarks on this. Thanks.
Thank you, Girish. Thank you, Mark. It's really a pleasure to be here and to have been listening to all these people who basically say, making the impossible possible. And what we learned from this session is that PARC has been able to foster collaboration between countries and between LMIC, and this has been a wonderful experience. So it didn't start with PARC, and we have to identify, also to remember the giant here. I remember the first publication from Giuseppe Macera, from also Raul Ribeiro when he went to Recife and say we can improve the survival, from Catherine who is here. And I remember the beginning of the LMC experience where you started with the COP because by giving a very high dose of chemotherapy to these kids with advanced lymphoma, they were all dying. So we learned from also what we see in these countries. And what is important, I think, is to make sure that the development of protocol in LMIC are not a copy and paste of the COG or the SIOP protocol. I see so many times people who say, oh, we use this protocol that we got from somebody who gave it to somebody who gave it to somebody, and we use it and the patient died after the first course of chemo because it's not adapted to a situation where the kids are different from the kids in high-income countries. And that's where we need you, who are dealing with 90% of the children on this planet. What we didn't hear about is also what are the big obstacles, and I think one of the big obstacles here is the lack of universal health coverage. Should we only offer, clinical trial to kids whose parents are able to afford the treatment? And that's a critical issue that we need to address. In many countries, children are only treated if the parent can afford the treatment. And that's one of the big limitations. But there is hope, and we can see also that with PARC, there is a collaboration going on. There are clinical trials that are developing. And what is interesting is, I'm always fascinated to see that with a grant of 75%, you can build a network of clinical trials in Latin America, where when I did my first clinical trial of amlastin, I got a grant of $250,000 to treat 50 patients, and this was already a lot of money. When I did the number 3, because of the complexity and the bureaucracy of clinical trial in high-income country, I had to get a grant of $2.5 million to treat 100 patients. So I hope that PARC will avoid this escalation of, needs, because the bureaucracy is killing clinical trials. And I want to say there is hope, and I remember 2 years or 3 years ago, I met with the people from day one, and I told them, I said, can you have at least 1 or 2 centers in low and middle income countries? And so I was very glad to see that the clinical trial of tovorafenib is now open in Brazil, which is a upper middle income country, but also in Jordan. So it's happening, and we also collectively, people from high income countries should push just to make sure that we promote for the participation of institutions from low and middle income countries, just in clinical trial assessing new drugs. But by having the PARC, you demonstrate your capacity to do this, and that's a very, very important factor. If you demonstrate, you will get the trust from the drug company. So having said that, I want to congratulate you for the work that you have been doing, and you too for your leadership, and Guillermo and Cassie for what you have put in place formally within SIOP. Thank you very much. Great. What a ride, right? And we were on time. It's a miracle, right? There were a lot of panelists. Thank you very much. Thank you, dear Chairman. You are doing a great job chairing the PARC committee. So thank you very much again. Looking forward for more participation at PARC.